Loriana is 2 years old. Like many other children her age, she is alert and active. But not long after Loriana was born, her mother began to notice that she was not at all like the other children her age.
She could take a few steps, but then she was falling, bumping into walls. And when she was crawling, she would walk in the walls. She would talk, but she wouldn't call me mama. She didn't know me. She didn't know anybody.
One day, while her mother was at the optometrist, she happened to pick up a brochure about Operation Bright Start, a program that provides free eye exams for infants. She asked the doctor if she could schedule an appointment for Loriana. Dr. David Sullins is the primary eye care optometrist who was the first doctor to perform a definitive eye exam on Loriana.
When Loriana came into the office, it was apparent that she had a condition called leukocoria, where one pupil was white and one pupil was normal and black. Upon closer examination with a microscope, we were able to determine that she did, in fact, have a persistent pupillary membrane. And this is where the pupil is actually tied down by scar tissue during uterine development that is supposed to be dissolved. However, it was not dissolved, and it adhered her pupil margin to the front portion of her lens. So she was not getting light to her retina, and without that, she would have had some severe developmental and eye problems as she matured through regular life.
Loriana underwent 2 operations before the problem was corrected. Fortunately for her, she was diagnosed and treated early before the disease could cause any permanent damage.
If Loriana had not been examined, the eye would have never had light to the retina, the eye would have never developed in a normal fashion, and she would have had, for all practical purposes, a blind eye.
Loriana's future looks bright.
The outcome was excellent. As you might imagine, she was quite sensitive to light because she hadn't had any light in the eye for almost 11 months of her early neonatal development, so she's doing quite well.
Her mother is even more pleased.
I'm so happy. I never thought that she would be able to do the things that she does now. Like, she wants to go outside all the time. She don't want to stay in the house. She watches TV. She loves to watch TV. She'll feed herself. She runs and plays just like all the normal children. And she notices me.
Stories like Loriana's have a happy ending because an optometrist was able to examine her when she was an infant. But not all children are so fortunate. In fact, many eye doctors feel unprepared to examine infants. They prefer to wait until the child is old enough to talk and to follow the examiner's instructions.
You have to have the opportunity to kind of brush up on the skills of how to examine the infant. It's virtually the same thing you do to an adult. It's a different set of circumstances. It's a different set of sequences in how you examine the child. However, most of the tests we do are quite objective, and it doesn't require the child to elicit a response at all. So as long as the child is well fed, dry, and for the most part happy, the drops and the lights that we shine in the child's eye is pretty normal, and the child reacts to it very nicely.
Examining children is child's play, according to Dr. Carol Marusic, a well-known optometrist in private practice in Eugene, Oregon. Dr. Marusic specializes in the developmental vision and eye health care for infants, children, and adults.
Every infant should have a vision and eye health examination. This examination can detect conditions that interfere with normal vision development. Without an eye examination, some children may suffer inadequate school readiness or, at worst, blindness. Retinal abnormalities, cataracts, glaucoma, retinoblastoma, amblyogenic refractive conditions, and eye muscle imbalances can all be identified with careful examination. How early should assessments begin? Examination of the eyes can be performed at any age, beginning in the newborn period. Infants at risk for problems such as retinopathy of prematurity, those with family histories of congenital cataracts, retinoblastoma, and metabolic or genetic diseases should of course be examined as early as possible. In fact, all infants should be examined by 6 months of age to evaluate fixation, binocularity, and to rule out eye disease. These infants should continue to be checked regularly throughout their preschool years. The vision examination should be performed early, since small children rarely complain that one eye is not seeing properly. Conditions that interfere with vision are of vital importance, and normal visual development requires the brain to receive equally clear, focused images from both eyes simultaneously for visual pathways to develop properly. Examination of infants does require special techniques. Many doctors may not be familiar with these techniques, so testing is often delayed until the child is older. By that time, though, the damage may already have been done, and the opportunity for normal development disrupted. So how do you test a baby's eyes? It really is child's play, and here are some of the most important tools for infant examination. When working with infants, the important thing is to get in and get out as quickly as possible before you lose their attention. It's best to have all your equipment readily accessible so you can get to it quickly. Lenses that you can use for retinoscopy, prisms that you're going to be using during testing, skioscopy bars that you'll use during retinoscopy, and your scopes so that you can quickly switch out your transilluminator and your ophthalmoscope head for different parts of the examination. Perhaps the most important equipment that we have is what's hidden here in the drawer, and those are the targets that are really going to hold their attention while you're testing. So we have quiet targets, targets that make no noise but are very visually stimulating, so we can capture their attention by just visual input. We want ones that are animated and that can really hold them. We also want targets that we can light up so you can see the reflex when looking at the target. I find that yellow finger puppets work the best. You get a good strong reflex with those. The other kind of targets we want to work with are noisy targets that can help to attract their attention when we're doing muscle field testing. We want to know, can they get there? And so we'll use every trick at our disposal to do that. Bells that can attract their attention and can be attached to other pieces of equipment. Rattles that are visually pleasing and also noisy. Let's go through an infant examination so you can see how readily it can be done. All right, come on in, Sandra. You can have a seat right here. Good. Why don't we put Sarah down so she can play while we just go over the history that you already filled out for me.
There you go, Sarah.
Thank you for taking the time to fill this out ahead of time. That really is helpful. So I had a chance to review it, and it seems like... Be sure to request a history ahead of time so the baby does not tire when you read over it. Remember, they will fatigue quickly, and you don't want to waste any ready time talking with mom. This way you can simply review the highlights or problem areas with the parent before the infant is positioned for the exam. Okay, then what we'll do is we'll pick up Sarah and we'll go ahead and get her set so that she'll be in our ready position and we can work with her. We like to have her play while we talk so that she doesn't get antsy. Okay? Right. Very good. Come on with me. Right, so we're just going to go through each thing one at a time. And so we'll start with where we play peekaboo with the light. Ready? Peekaboo, peekaboo, peekaboo. Good girl. And we just look right at that light. Good job. Peekaboo, peekaboo, peekaboo. Good girl. And again, here it goes. Oh, look at that. Good girl. Very nice. Now we're going to do this one. Ready? Here we go. Okay, Mom, you want to hold her head for me, please? And here we go again. Here we go. Sarah! Sarah, okay. Good girl. Over here, Sarah. Over here, Sarah. Good. And we'll pull something else out. Ready? Okay. Here we go. Here we go. Here. Good girl. And here. Good girl. And down here. And up here, Sarah. Good girl. Good. Yes. Ready? Here it comes, Sarah. Here it comes, here it comes, here it comes. Good girl. Very nice. Ready? Look at this one. Yeah, look at it. Yes, which one are you going to take? Good girl. Let's get another one. I'll do this one. Right? So, ooh, good. And then I need to change hands. Ready? Here we go. Oh, once you touch it, you're too interested. Let's do it again. Ooh, and again. Sarah! Sarah! Here we go. Ooh, yes, very good. Oh, hard. Ready? Peekaboo. Look right here. Good girl. Nice reflexes. Good job. Let's look at this one. And we're going to just look back and forth. Good. And then we're going to look up here. And look in there. And then oh, what's that light doing? What's that light doing? Good girl. Let's take a look with my other big lens. Here we go. Ready?
Come on. Good.
Here we go. Good. Sarah, peekaboo. This one. There we go. Good girl. Let's do the other eye. Sarah. Uh-oh. Choo. Sarah. There we go. Good job. Ready? Sarah. Here we go. Good girl. This one. There we go. Woo, woo. Good girl. Woo, woo, woo. Ready? Sarah. Look right here. Look at that doll. Good girl. Very good. And let's look at this one. Good job. Let's take a different one. Ready? Good girl. And another one. Here it comes. There we go. Good girl. Good job. And then we're going to put a little drop in each eye.
Come here.
Okay? And we have something to suck on already, huh? Right with her eyes closed, just like
Good
that.
girl.
And a little bit there. And let her
Good
rub.
girl.
You can just sit her up and let her rub.
Good
Want to rub
girl.
those eyes? Go ahead. Good girl. And then we're just going to wait a little bit while those drops work, and then we'll come back in and take a look. Okay?
Okay.
Thank you. Hello, Henry. Hello, Henry. Good job. Oh, this one. Good girl. Good job. Very good. Let's go to the other eye. Ready? Here we go, baby. Ready? Let's take a look. Okay, you did a great job. Good work. And so eye health is normal. There's no sign of any disease, no abnormality at all. Vision development is right on target, right where it should be. See, she's happy about that. And so no signs of any problems right now. She's a little tiny bit farsighted, and we expect that at this age. There's lots of changes in refraction during that first year, and so we'll just watch carefully and make sure it stays within that typical range where it should be. We'd like to see her again at about 18 months. That's when we see a high incidence of eyes tending to wander. Again, at 2.5 and 3, there's another stage where we see big changes in vision. And then, of course, we'll check her again before she gets into kindergarten. So make sure she's developmentally ready for success in school. I also have a pamphlet for you that has some information about things to watch for. So if you see any signs or symptoms of things that you read about in here, bring her in right away, even if it's in between those scheduled appointments.
Okay.
Any questions at
No, I
all?
think that's good. Thank
No,
you.
You did a great job. You too. Good job. Thank you very much.
You want to read this?
Let's go back and review each procedure. How is it done, and what are we looking for? Once mom and baby are settled, talk to the baby so she can get comfortable with you. There we go. All right, so we're just going to go through each thing. Play a game, something familiar with a bright light like peekaboo, something exciting. Peekaboo, peekaboo, peekaboo. Good girl. And we just look right at that light. Good job. Peekaboo, peekaboo. Once you get her attention, then you can cover one eye with either your hand or a thumb to look at angle kappa. And with both eyes open, look at angle Hirschberg and see how the eyes are aligning. With another toy. If the light becomes boring or too bright, switch to a bright light toy, a finger puppet. And that's okay if she touches. Yeah. Oops, you got it. Yeah, let's do it again. And now we're going to do it with a thumb. Can you see that there? Occupy a hand. Okay. Cover test allows you to determine eye alignment and motor fusion. Ready? Here we go. Do you want something to do? It's a little big. Let's give you this one. Okay. Now we have both hands occupied. Ready? Here we go. Sarah. Boop. Look right there. Good girl. Look again. Here we go. Good girl. Look again. Here we go.
Good girl.
To check muscle fields, you want to use a visual and auditory target, so we have both modalities attracting her attention into every position of gaze. Another way to accomplish this would be for mom to hold her head still while you move the target into all positions. Ready? Or to hold the target still and have mom move the baby's head up, down, left, right. The goal is simply to make sure the eyes can get into each position. When we're looking for visual pursuit tracking, we want to use a quiet target, one that does not have auditory stimulation. Again, we can accomplish this by moving the target into all positions of gaze with mom's help to hold the baby's head still, or we could have mom move the baby's head while the target is held still.
Good.
Convergence can be tested both with a noisy target and with a visual target. A lighted target on the end of your transilluminator is an excellent source.
Good.
The visual target makes it easier to see eye alignment as the target is moved closer to her nose.
Good girl. Very nice.
Ready? 10 base up prism test is used to determine if the baby is paying attention through both eyes simultaneously.
Good girl. Let's get another.
When looking through both eyes and one is covered by a 10 base up prism, the baby sees two images. You can see the eyes switch from one image to the other by moving up and down depending on her attention. Confrontation visual fields are best accomplished with a combination of noisy and quiet target. A noisy target to initially attract her attention centrally allows you to introduce a very enticing peripheral target and see if she can switch her attention from one to the other.
Oh, once you touch it.
When she has been able to do that in every position of gaze, you know that the confrontation visual field is intact. Be sure to give the baby enough time to respond, so you know that they really can see in all fields of gaze. The Bruckner test is completed in a dark room with your ophthalmoscope light lighting up her entire face. You look at the response in each pupil for media clarity, indications of strabismus, amblyopia, or significant refractive condition. By judging the reflex from each eye, symmetry, brightness, and clarity, you can determine a lot about how this infant is functioning. Here are a number of examples of how the eyes might appear in different conditions.
Let's look at this one.
Because babies are so interested in your light, pupillary responses are easy to read.
Oh, what's that light doing? What's that light doing? Good girl.
Come on.
Using your transilluminator light in combination with your BIO 20 diopter lens allows for excellent magnification when evaluating external eye structures.
Sarah, there we go. Good job. Good girl. There we go. Good girl. Ready?
Mohindra retinoscopy is the most appropriate form of retinoscopy when working with infants. Again, this is completed in a dark room with monocular viewing.
Ready? Sarah.
With your retinoscope at 13 inches, occlude one eye and introduce lenses as needed to neutralize the reflex.
Good job. Let's take a different one. Ready?
Right on this.
Good.
This can be accomplished by using your hand to block the eye not being tested,
Girl. Good job.
or by use of a patch or occluder.
And now you probably do want to hold her hands down a little bit. There we go. And let's
Good girl.
While loose lenses may allow for easier retinoscopy, a skiascopy bar can also be used to judge the initial starting lens.
Here we go. We may have to hold those hands. Okay. There we go. Good girl. Good. And let's take a look. There we go. Good job. Oh, look at that girl. Good job. Very nice.
When introducing drops to the infant, it is not necessary to have their eyes open. Simply introduce the drop with the eyes closed to the nasal canthus. The baby will do all the rest, opening her eyes and rubbing the drop in.
While those drops work, and then we'll come back in and take a look.
Monocular or binocular ophthalmoscopy is the easiest way to perform a dilated fundus examination in infants. If your baby is too fussy to complete the examination, remember to always end on a happy note, if possible, and reappoint for another day. If findings are normal, advise the parents regarding general visual development and when follow-up examination would be appropriate. If you have detected eye health problems, schedule appropriate consultation and initiate treatment. If you have detected vision problems, reappoint for further evaluation. If the baby can fix and follow equally and has no aversion to occlusion, you can infer that vision is not significantly different between the two eyes. If you suspected a significant difference in monocular response, there are special tools available to evaluate vision in infants. Referral for that evaluation may be appropriate based on what your findings are. Remember that infant vision can change significantly, and you want to be sure your findings are consistent over time before prescribing any lens which may interfere with emmetropization. Do recommend visual stimulation activities, especially emphasizing the more ametropic eye to encourage visual development. With your many years of experience examining the vision and eye health of all your patients, you can have full confidence in your ability to provide these same services for your infant patients as well.
Eye examinations are vital for the well-being of infants and children. Delaying eye testing till the child is much older can have tragic consequences. It's important for optometrists to be familiar with the tools and techniques for examining infants. So there will be more stories with happy endings, like Loriana's.